This session will discuss informatics tools to promote patient safety. At the end of this session, you will be able to examine strategies for developing a safety culture, assess how human factors contribute to errors, and describe the impact of informatics technology on patient safety. Nursing professionals have an ethical duty to ensure patient safety. Increasing demands on professionals in complex and fast-paced healthcare environments, however, may lead them to cut corners or develop workarounds that deviate from accepted and expected practice protocols. These deviations are not carried out deliberately to put patients at risk, but rather are often practiced in the interest of saving time or because the organizational culture is such that risky behaviors are commonplace. Occasionally, these inappropriate actions or omissions of appropriate actions result in harm or significant risks of harm to patients. In the 1999 to 2000 Institute of Medicine report to Errors Human is widely credited for launching the current focus on patient safety in healthcare. This report was followed in 2001 by the Institute of Medicine's Crossing the Quality Chasm report, which brought to national attention healthcare quality and safety. This national attention resulted in a $50 million grant by Congress to the Agency for Healthcare Research and Quality to launch initiatives focused on safety research for patients. Other initiatives prompted these seminal reports were the Joint Commission's National Patient Safety Goals of 2002, the National Quality Forum's Adverse Events and Never Events lists in 2002, the creation of the Office of National Coordinator for Health IT to Computerized Healthcare in 2004, the formation of World Health Organization's Alliance for Patient Safety in 2004. The Institute for Healthcare Improvements had 100,000 Lives campaign in 2005 and the 5 Million Lives campaign in 2008. Congressional authorization of patient safety organizations created by the Patient Safety and Quality Improvement Act to promote blameless error reporting and shared learning in 2005, and the No Pay for Errors initiative launched by Medicare in 2008, and the $19 billion congressional appropriation to support electronic health records and patient safety. Key features of a safety culture identified by the Agency for Healthcare Research and Quality are as follows. Acknowledgement of the high-risk nature of an organization's activities and the determination to achieve consistently safe operations. A blame-free environment where individuals are able to report errors or near misses without fear of reprimand or punishment. Encouragement of collaboration across ranks and disciplines to seek solutions to patient safety problems, and an organizational commitment of resources to address safety concerns. Failure modes and effects analysis, or FEMA, is a systematic, proactive method for evaluating a process to identify where and how it might fail, and to assess the relative impacts of different failures in order to identify the parts of the process that are most in need of change. This powerful tool and shared experience from other organizations can be viewed at this website. An important part of safety culture is cultivating a blame-free environment. Errors or near misses must always be reported so that they can be thoroughly analyzed. All organizations can learn from their mistakes and change their organizational processes or culture to ensure patient safety. The Patient Safety and Quality Improvement Act of 2005 mandates the creation of a national database of medical errors and funded several organizations to analyze these data with the goal of developing shared learning to prevent medical errors. Organizations themselves can engage in a root cause analysis or failure modes and effects analysis to examine medical errors closely and to determine the system processes that need to be changed to prevent similar future errors. If one embraces a blame-free environment to encourage error reporting, then where does individual accountability fit in? According to the Agency for Research in Healthcare Quality, one way to balance these competing cultural values, that blameless versus accountability, is to establish a just culture, where system or processes issues that lead to unsafe behaviors and errors are addressed by changing practices and workflow processes, and a clear message is communicated that reckless behaviors are not tolerated. The just culture approach accounts for 3 types of behaviors leading to patient safety compromises: human error or unintentional mistakes, risky behaviors or workarounds, and 3, reckless behavior or total disregard for established policies and procedures. Strategies for achieving a safety culture have been addressed frequently in the literature. The focus here is limited to those strategies described by 2 key organizations: the Agency for Healthcare Research and Quality and the Institute for Healthcare Improvement. The Agency for Healthcare Research and Quality provides access to data from 2 validated surveys, the Patient Safety Culture Survey and the Safety Attitudes Questionnaire. The Agency for Healthcare Research and Quality suggests that teamwork, training, executive walkarounds, and unit-based safety teams have improved safety culture perceptions but have not led to a significant reduction in error rates. The Institute for Healthcare Improvement stresses that organizational leaders must drive the culture change by making a visible commitment to safety and by enabling staff to share safety information openly. Some of the strategies suggested by the Institute for Healthcare Improvement include appointing a safety champion for every unit, creating an adverse event response team, and reenacting or simulating adverse events to better understand the organizational and procedural processes that failed. A systems engineering approach to patient safety, in which technology manufacturers partner with organizations to identify risks to patient safety and promote safe technology integration. Human factors engineering is the discipline of applying what is known about human capabilities and limitations to the design of products, processes, systems, and work environments. Its application to system design improves ease of use, system performance, reliability, and user satisfaction while reducing operational errors, operator stress, training requirements, user fatigue, and product liability. For example, the feel of an oxygen control knob that is rotated smoothly between settings, suggesting to the user that oxygen flows at all points on the knob, when in fact oxygen flowed only at specifically designated liter flow settings. Human factor engineering testing would most likely reveal this design flaw, and the setting knob could be improved to include discrete audio or tactile feedback where it clicks in place, so the user will be able to indicate a point on the dial where the oxygen flows. Testing human use factors provide more objective safety data than the subjective responses gained from user preference testing. Understanding how the equipment shapes human performance is as important as evaluating reliability or other technical criteria. Organizations that are purchasing medical technology devices should avail themselves to all of the shared safety data on equipment maintained by several key organizations, including the Joint Commission, the Food and Drug Administration, and the Medical Product Safety Network. Once technology is integrated into the organization, biomedical engineers can become valuable partners in promoting patient safety through appropriate use of technologies. For example, in one organization, the biomedical engineers helped to revamp processes associated with new technology alarm systems after they discovered several key issues: slow response times to legitimate alarms and multiple false alarms, promoting alarm fatigue created by alarm parameters that were too sensitive. Strategies for addressing these issues included improving the nurse call system by adding voice over internet protocol telephones that wirelessly receive alarms directly from the technology equipment carried by all the nurses, thus reducing response times to alarms. Feeding alarm data into a reporting database for further analysis, and encouraging nurses to work with physicians to provide input into alarm parameters that were too sensitive and were generating multiple false alarms. The research brief describes a study of intelligent agent, or IA technology, to improve the specificity of physiologic alarms. Clearly, there is more work to be done to create safety cultures in complex healthcare organizations and to reduce the incidence of errors. Many organizations are looking into informatics technology to help manage these complex safety issues by using smart technologies that provide knowledge access to users, provide automated safety checks, and improve communication processes. Healthcare technologies are frequently designed to improve patient safety and streamline work processes, as well as improve the quality and outcomes of healthcare delivery. Technology is not always the answer to patient safety, as the Joint Commission in 2008 cautions. The overall safety and effectiveness of technology in healthcare ultimately depends on its human users, and any form of technology can have a negative impact on the quality and safety of care if it is designed or implemented improperly or is misinterpreted. Although technology may certainly help to prevent or reduce errors, one must always remember that technology is not a substitution for safety vigilance by the healthcare team and a safety culture. The adoption of information technology processes to improve safety has been recommended by several groups. It is suggested that information technologies improve communication, reduce errors and adverse events, increase the rapidity of response to adverse events, make knowledge more accessible to clinicians, assist with decisions, and provide feedback on performance. They also describe the benefits of technology-based forcing functions that direct or restrict actions or orders implemented by computer technologies. For example, physicians may be forced to write complete and accurate medication orders, restricted from ordering an inappropriate dosing route for a medication, or prompted to write corollary orders that should be included in the care regimen as part of the standard of care. The National Patient Safety Foundation in 2013 listed the top patient safety issues as wrong site surgery, hospital-acquired infections, falls, hospital readmissions, diagnostic errors, and medication errors. Many of these issues can be prevented or detected in their early stages using informatics technologies. Other technologies designed to promote patient safety include wireless technologies for patient monitoring, clinician alerts, point-of-care applications, and radio frequency identification applications. The steps in the medication administration cycle, an assessment of need, ordering, dispensing, distribution, administration, and evaluation, have been relatively stable for many years. Each of these steps depends on vigilant humans to ensure patient safety, resulting in the 5 rights of medication administration. 1, the right patient, 2, the right time and frequency, 3, the right dose, 4, the right route, and 5, the right drug. Human error can be related to many aspects of this cycle. Distractions, unclear thinking, lack of knowledge, short staffing, and fatigue are a few of the factors that cause humans to deviate from the accepted safety practices and commit medication errors. Integration of technology into the medication administration cycle promises to reduce the potential for human errors in the cycle by performing electronic checks and providing alerts to draw attention to potential errors. Computerized physician or provider order entry is an electronic prescribing system designed to support physicians and nurse practitioners in writing complete and appropriate medication and care orders for patients. When CPOE, or computerized physician or provider order entry, is part of an electronic health record with a clinical decision support system, the medication order is electronically checked against specific data in the patient record to prevent errors, such as ordering a drug that might interact with the patient's weight, or ordering a drug that is contraindicated by the patient's allergy profile or renal function, or ordering a dose that is that may interact with the drug the patient is already taking. Because it is impossible for and unreasonable to expect a clinician to remember each of the more than 600 drugs that require a dose adjustment in case of renal dysfunction, for example, safe dosing parameters are provided by the CPOE. In a standalone CPOE system without a clinical decision support system, the medication orders are simply checked by the computer against the drug database to ensure that the dose and route specified in the order are appropriate for the medication chosen. Specific benefits of CPOE include the following: prompts that warn against the possibility of drug interaction, allergy, and overdose; accurate current information that helps physicians keep up with new drugs as they are introduced to the market; drug-specific information that eliminates confusion among drug names that look and sound alike; improves communication between physicians and pharmacists; and reduced healthcare costs caused by improved effectiveness and efficiencies. CPOE solves the safety issues associated with poor handwriting and unclear or incomplete medication orders. Orders can be entered in seconds and from remote sites, limiting the use of verbal orders that are especially subject to interpretation errors. Orders are then transmitted electronically to the pharmacy, reducing the potential for the transcription errors commonly encountered in the paper-based systems, such as lost or misplaced orders, delayed dosing, or unreadable faxes. Thus, CPOE changes workflow for all clinical staff and physicians, as well as health team communication patterns. As with any technology integration, introduction of CPOE is associated with a resistance to change and a learning curve to gain proficiency, and users must learn to trust the system. Manner in 2010 urges careful planning and training during implementation with plenty of staff support. She also reports on the need for a paper-based backup system in the case of a network or electrical outages or system maintenance. The verification and dispensing functions of the pharmacy can also be assisted by technology. The pharmacist begins by verifying the allergy status of the patient and the medication reconciliation information to ensure that the new medication is compatible with other medications in the care regime. This verification function is computer-based, and the medication order is electronically checked via the knowledge database. If the order is verified as safe and appropriate, the pharmacist proceeds to the dispensing process. Barcode medication labeling at a unit dose level was mandated by the Food and Drug Administration in 2004, with targeted compliance to be achieved by 2006. A barcode is a series of alternating bars and spaces that represent a unique code that can be read by a special barcode reader. Barcode technology spans both the medication dispensing and administration steps in the medication administration cycle. In the pharmacy, the barcode helps to ensure that the right drug and the right dose are dispensed by the pharmacy. Medications that are labeled with barcodes can also be dispensed by robots capable of reading the codes or by automated dispensing machines. In this way, barcode technology helps with the process of procurement, inventory, storage, preparation, and dispensing. The processes of drug storage, dispensing, controlling, and tracking are easily carried out via automated dispensing machines, also known as automated dispensing cabinets, unit-based cabinets, automated dispensing devices, and automated distribution cabinets. These devices have benefits for both the user and the organization, specifically in the areas of access security, especially with narcotics administration tracking, safety, supply chain, and charge functions. Barcode medication administration systems help to ensure adherence to the 5 rights of medication administration. Whether BCMA is part of a larger EHR or a freestanding electronic medication administration system, or EMR, barcode technology provides a system of checks and balances to ensure medication safety. The nurse begins by scanning his or her name badge, thereby logging in as the person responsible for the medication administration. Next, the barcode on the patient's identification bracelet is scanned, prompting the electronic system to pull up the medication orders. Next, the barcode on each of the medication is to be administered is scanned. This technology check ensures that the 5 rights of medication administration are met. If there is a discrepancy between the order and the medication that was scanned or a contradiction for the administration, an alert is generated by the system. For example, in an electronic health record with a clinical decision support, the nurse may be prompted to check the most recent laboratory results for electrolytes before administering a potassium supplement. In a freestanding EMR without CVS or EHR links, if the medication orders have recently been changed, the nurse is alerted to the change. When an alert is generated, the nurse must chart the action taken in response to that alert. For example, an early dose might need to be given if the patient is leaving for the unit for a diagnostic test. Despite the promising advances in patient safety afforded by this technology, it is not fail-safe. Medications that are labeled individually by the in-house pharmacy increase the potential for human error if the medication is given an incorrect barcode, such as one signifying a wrong dose or even the wrong medication. In addition, the barcode printers themselves may generate unreadable labels, leading to staff workarounds in the interest of saving time. The following are recommended to reduce barcode administration errors whenever possible. 1, purchase unit of use medications with manufacturer barcodes whenever possible. 2, double-check all hospital-generated barcode labels, including those for compounded injectable medications before the product leaves the pharmacy. 3, carefully review all barcode medication administration override reports. Address system workarounds through process change and staff education. 4, minimize false positive warnings to reduce the likelihood that staff will ignore warnings for real errors. 5, ensure that an urgent need exists for all stat orders, as pharmacy review and advantages of barcode administration are usually circumvented in such cases. And 6, establish institutional policies and procedures that can be easily implemented when products fail to scan. Processes in pharmacy will likely be different from processes at the point of care or at the bedside. Smart pump technologies are designed for safe administration of high-hazard drugs and to reduce adverse drug events during intravenous medication administration. Smart pumps have software that is programmed to reflect the facility's infusion parameters in a drug library that compares normal dosing rates with those programmed into the pump. Discrepancies generate an alarm, alerting the clinician to a safety issue. A soft alarm can typically be overridden by a clinician at the bedside, but a hard alarm that requires the clinician to reprogram the pump so that all the dosing falls within the facility's intravenous administration guidelines for the drug to be infused. All alarms generated by the smart pump are tracked along with the clinician's responses to them. Smart pumps can be seamlessly integrated into the barcode medication administration systems, and data can be fed directly into the electronic health record. Clinical decision support, or CDS, can enhance the medication administration cycle by promoting safety and improving patient outcomes. Clinical decision-making is guided by targeted information delivery, ensuring that the 5 rights of CDS are implemented. The right information provided to the right person in the right format through the right channel at the right time in workflow. For example, during medication selection, a CDS helps a clinician select an appropriate medication based on client data, such as clinical condition, weight, renal function, concurrent medications, and cost. This system ensures that the order is complete by performing checks for drug interactions, duplications, or allergy contraindication, and ensures the right dose and the right route are specified. During the verification and dispensing phase of the medication administration cycle, the CDS provides double checks for interactions, allergies, and appropriate dose orders. Consideration is also given to potential infusion pump programming issues, incompatibilities during infusion, and proper notation in dispensing when portions of a dose must be wasted. During the administration phase, the CDS assists with patient identification and current assessment parameters, for example, blood pressure and glucose levels, that may contraindicate the use of the medication at that point in time. In addition, checks for the interactions with foods and other medications and timing and monitoring guidelines are provided to the clinician administering the medication. The CDS has patient education guidelines and printable handouts to assist clinicians in educating patients about their medications. The monitoring functions provide a structured data reporting system to track side effects and adverse events across populations. Several promising technologies may become available in the future to assist patients with medication compliance or adherence after discharge. For example, eMed Online collects patient and medication compliance data by scanning packaged barcodes or radio frequency identification medication tags and using personal digital assistant or smartphone technology to send compliance data to the server. Clinicians review the medication compliance data and provide education and feedback to patients to increase their compliance with proper medication administration. The Seminal medication adherence system uses web-based technology to monitor patient compliance and provide reminders about taking medications or refilling prescriptions by sending text messages to the patient or caregiver. Caps of the pill bottles may contain radio frequency identification tags that monitor and collect data on the bottle when the bottle is opened, or that contain flashing time reminders when a dose is due. Smart inhalers track asthma medication compliance using a microprocessor that records and stores medication compliance. They also may include visual and audio reminders to use the inhaler. These are just a sampling of the newer technologies for medication adherence. More are expected to emerge in the future. Radio frequency identification, or RFID technologies, have both supply chain and patient care applications to patient safety. An RFID system contains a tag affixed to an object or to a person that functions as a radio frequency transponder and provides a unique identification code contained on a tag. The identification provides a unique code, and the reader receives and decodes the information contained on the tag and an antenna that transmits the information between the tag and the reader. When RFID tags are embedded in patient identification bracelets, they can help with the patient tracking during procedures and testing or function as part of the EHR, communicating pertinent information to clinicians at the bedside. RFIDs may be part of the medication administration process, replacing barcode technologies. They can be used to track medical supplies, inserts, and equipment, thereby reducing staff time in locating such items. They may also be embedded into surgical supplies to automate supply counting procedures, thereby reducing the likelihood that sponges or tools will be erroneously left in a patient. RFIDs may also reduce the likelihood of wrong patient, wrong site surgical procedures. RFIDs used in the medication supply chain protect patients by reducing the potential that a counterfeit medication might be inadvertently introduced to the supply and by providing for efficient medication recalls. Potential terrorist manipulation of the medication supply is also thwarted by RFID supply chain tracking technology. Blood and blood products can be efficiently tracked by RFIDs because specialized tags can detect temperature fluctuations and therefore ensure that the blood or the blood product was stored at the optimal temperature for safe administration. Smart rooms are being tested for wider use in healthcare. As a caregiver enters the room, the RFID on his or her name badge announces to the patient on a monitor, typically mounted on the wall in the patient's line of sight, exactly who has entered the room and triggers a need-to-know data based on caregiver status to be displayed on the monitor in the room. For example, when a dietary aide enters the room, only the dietary information is displayed. When a physician or nurse enters, all of the pertinent medical data from the EHR is available. Clinicians can review patient data in real time and chart care at the bedside using touchscreen technology, thereby increasing productivity. Some smart room technologies include workflow algorithms to alert clinicians as they enter the room about procedures that need to be implemented for the patient and can track individual clinician efficiency and effectiveness by aggregating data over time. New technologies to improve patient monitoring include wearable devices and wireless area networks, variously called body area networks or patient area networks. The technologies provide the ability to wear a small, unobtrusive monitor that collects and transmits physiological data via a cell phone to a server for a clinician review. Although most of these technologies are designed for monitoring patients with chronic diseases, they also have safety implications because they help identify early warning physiologic signs of impending serious health events. A wireless chip on a disposable Band-Aid with a 5 to 7 day battery promises to be able to monitor the patient's blood and heart rate, and electrocardiogram, blood glucose, blood pH, and blood pressure, allowing for the collection of important clinical data outside of the hospital. Wearable stress sensing machines or monitors detect electrical changes in the skin that may signal increased stress in autistic children who are unable to communicate an impending crisis. Caregivers are alerted to the potential crisis via wireless transmission and can intervene to reduce the stress and prevent the crisis. Several new technologies promise to aid in early detection of falls in elderly, including a wearable pendant that triggers a personal emergency response system. Technology in smart slippers with pressure sensors in the soles that transmit movement data wirelessly to a remote monitoring site. The human side of patient safety is paramount. As technologies that can help reduce errors and increase safety are integrated into caregiving activities, healthcare professionals must also improve their ability to use and manage these technologies. Therefore, not only must the technology be scrutinized and tested routinely, but the users must also be maintained and nurtured so that they are able to use the tools to the patient's benefit, avoiding harm and keeping the patient safe. Even the best CDS systems can contribute to mistakes by providing meaningless or harmful information. Nurse informaticists and the IT team in the facility must ensure that all systems are properly configured and maintained. They should routinely monitor and check these systems while making sure that their human potential, that is the users, is capable of using the systems accurately to avoid errors. A human technology and its user can never be left to their own devices. Human inputting activities must focus on patient safety to raise the appropriate issues and sound out solutions. Nurse informaticists must be involved in all stages of system development lifecycle while maintaining a focus on safety. Safety concerns and remedies need to be analyzed, synthesized, and integrated throughout the system development lifecycle to have a robust tool that provides meaningful information and enhances patient care while preventing errors and promoting patient safety.